Hello everyone, welcome to the clinical case outcome from this week. We have a 9-year-old male Neotrek Yorkshire Terrier that presented with peracute onset of non-progressive, non-painful, severely non-ambulatory tetraparesis. There were absent postural reactions on all 4 limbs. Spinal reflexes were normal on the pelvic limbs, but the withdrawal reflex was decreased on the thoracic. There was increased muscle tone also on the thoracic limb. The mental status was normal, and there were no clinical signs consistent with cervical hyperesthesia. So putting all of this together, where is the neurolocalization? So the neurolocalization, we can mainly say was C62. However, if you see this increased tone, doesn't really fit with the lower motor neuron. So it's also the possibility that this dog has a C1, C5 myelopathy. And there is a study back in 2008, where it was reported that the accuracy of the withdrawal reflex in dogs with intervertebral disc extrusion should not be reliable on determining your neurolocalization. So always consider more if you have increased tone on the thoracics that you should cover the investigation, considering that the clinical signs could be associated with a C1, T2 myelopathy. So putting all this clinical reasoning together, we have the 9-year-old male Neotrek Yorkshire Terrier with peracute onset, non-progressive, in this case was non-lateralized, non-painful C1-T2 myelopathy. And the main clinical signs, it could be either an acute non-compressive nucleus pulposus extrusion or an acute compressive nucleus pulposus extrusion. The main clinical characteristic in this case, it was not really painful. If there is a degree of intervertebral disc extrusion that is degenerated, they usually show signs of cervical hyperesthesia. Other differential, because of the peracute onset, because of the non-progressive and the fact that was non-painful, is an ischemic myelopathy. So in this case, we underwent advanced imaging of the cervical vertebral column, and if you haven't done it yet, as I always say, I would recommend that you hear the MRI description on this case that was done by Fraser. And the MRI abnormalities was find this abnormal C3, C4 intervertebral disc there was the reduced volume of non-degenerated nucleus pulposus. There was a small defect in the dorsal part of the annulus, and there was this abnormal fluid signal extradural ventral to the spinal cord with this shape that could be consistent with the Siegel sign, and there was moderate spinal cord compression. So the MRI differential was an acute extrusion, non-degenerate, so hydrated nucleus pulposus. So what do we know about this type of intervertebral disc? So when we talk about, based on the literature, these were previously known as discal cyst or ventral spinal cyst. The only thing, because that was mainly based on the MRI features, but what it was seen is that the clinical signs didn't really fit with a cyst, because all these dogs presented with peracute onset of severe myelopathy and didn't show any signs of clinical signs of myelopathy prior to the onset. And if you have a cyst, that takes time to develop, so it's not really a peracute onset. So a year later, we wrote this paper on the clinical signs and magnetic resonance imaging features of suspected hydrated nucleus pulposus extrusion. At that time of writing this paper, we didn't have any histopathology on the extruded material, therefore it could not make and confirm hydrated nucleus pulposus extrusions. But further studies has come out, and then this hydrated nucleus pulposus herniation in 7 dogs, where it was histologically confirmed that the extruded material, or the material that was at that level with this cystic-like structure, it was consistent with hydrated nucleus pulposus. So what do we do with these cases? Do we treat them conservatively? Do we treat them surgically? And when we wrote the first paper, because of the severity of the compression, we mainly decided to go on surgical based on the clinical signs and the severity of the compression. So where the spinal cord was compressed around 24% or more than 24%, those cases on that study did undergo surgery. However, over the years, years about learning about this type of intervertebral disc extrusions, we have seen that the majority of the cases do not require surgery. When we perform surgery at the level of the cervical vertebral column, goes to a ventral slot, and the extruding material, you can see this video, is a courtesy for a friend of mine, is Dr. Daniel Corlazzoli, and you can see this hydrated nucleus pulposus is really hydrated, really watery type, is very gelatinous. So on those cases, what we now tend to do is that see how the dog progress within the first 24 hours. So it's important also to know that obviously a presentation, because usually the myelopathy is quite severe, if they have respiratory issues, because sometimes you can have the axons that goes through the phrenic nerve also compromised. Some of them, they do require surgical decompression, but if they don't have issues on the respiratory system, usually we see how they do over the first 24 hours, and you can see this dog after 24 hours from the onset is already showing some better movement. This is just 48 hours after the onset, and you can see is already ambulatory, and this is just 3 days after the onset, and the dog is ambulatory with any kind of assistance. So what is likely is that the spontaneous regression on this type of intervertebral disc extrusions is likely to be related to the chemical inflammation reaction of the extruded material, and obviously that neovascularization, which are thought to be required for the phagocytosis, and being so hydrated is no surprising that they can do well on conservative management. So I hope you enjoy this case. I hope you learned from it. And if you have any question, please let us know. Otherwise, we'll see you next week with another case. Thank you.